introducing us, right? Yeah. All right. I want to thank everybody for bearing with us while we had technical issues. So I want to welcome everybody to our session on narrative medicine called Bringing Humanity Back to Medicine. My name is Maura Davenport. I'm the Associate Program Director and Medical Education Fellowship Director at Allegheny General in Pittsburgh.
Hi guys, I'm Suchi, but most of you guys here know me. I'm one of the ER attendings at NYU Long Island. I'm the Director of Research and a med ed fanatic.
Hi everyone, I'm Kamna Balhara. I'm at Hopkins. I have no fancy titles.
Yeah, exactly. She doesn't need a fancy title, that's for sure. So we are all relatively non-controversial. We have no disclosures. So I'm just going to get that out of the way. So we have a few objectives for today. The first thing is we want to discuss the role of narrative medicine in emergency medicine. We also want to explore ways that you can participate in narrative medicine exercises, and we will have you all go through a narrative medicine exercise. And then we want to identify some of the tools that you will need to actually be able to implement these narrative medicine exercises into your EM curriculum.
So the originator of narrative medicine, who's a physician named Rita Sharon at Columbia, she clearly tells us that the care of the sick unfolds in stories. And in our work as emergency physicians, we are always telling stories, hearing stories. We're crafting stories when we write a note in the EHR. But all those stories come from so many different sources, right? You have your patient giving you one story, but maybe your medical judgment or the results of your tests tell you a different story. And then the EHR has its own narrative about the patient's visits through the healthcare system. And then when we're signing out and talking to our colleagues, that's a whole other set of stories that's being generated. So how do we bridge all these different sources of data? How do we bridge pathophysiology and our medical knowledge with the experiential expertise that patient is bringing to us with their stories? And we'd like to propose that narrative medicine represents that bridge.
Okay, so I'm going to put you guys on the hot spot. What's narrative medicine? Storytelling. What else? Asking questions about the patient so that they can tell their story. Anyone else? Any other takers? Go for it. Ethnography. Okay, ethnography. Very nice. Anyone else? Any last ventures? Okay, so all of us have different interpretations of what narrative medicine is, what it can be, but if you guys want to get technical, it's really an educational tool. It uses, sorry, I got distracted by Yash taking a picture of me. Thank you, Yash. It uses a pedagogical framework and the medical humanities to accomplish its objectives. So basically, it uses 3 steps, a close reading of the medical humanities, followed by deep reflection and then group discussion. And what are those objectives that it's trying to accomplish? It's trying to help us practice medicine with this concept of narrative competence. So what's narrative competence? Narrative competence is this ability to elicit the patient's story, both through verbal and nonverbal cues, to interact with it critically, and also to respond to it. And you're going to be like, how? How does it do that, Suchi? And that's a loaded question with a very long answer. But basically, there's some evidence that suggests that the neuronal pathways that are activated when you engage with creative work are pretty much the same neuronal pathways that are activated when you're doing any kind of critical thinking. So when you read texts, when you look at a picture, when you try to understand what a poem is trying to say, you're going through the same pathways. And through this, narrative medicine helps to develop attention, it helps you develop reflective skills, it helps you explore a diversity of perspectives, and it helps you share and strengthen relationships with your colleagues, with consultants, with the patient's family, nurses, the whole care team.
So what are some things that you can do as part of narrative medicine? And one of the most basic things you can do is reading. So we have gone through reading multiple textbooks throughout our medical careers, but there's also the other side of medicine. It is the art of medicine, not just the science. And books like this will really show us the other side of medicine. These readings teach us how to listen. they help us work on our empathy, and they help us by combining our listening and our newfound empathy. We can really work on advocacy, and it's a really nice way to interact with your patients and to actually improve their outcomes long term. The thing about that it's narrative medicine is not just for the patients, it's for us as clinicians. It's for all of our staff in the emergency department. And as Dr. Darwood is referring to, that narrative medicine will help us improve multiple aspects of our clinical practice, things like our relationship building. It's much easier to interact with your patient when you have a little bit more sense of where he or she is coming from their perspective. It just broadens your perspective globally in terms of not just medicine, but social issues as well. And taking these newfound advantages and these new pieces of information, they actually improve our clinical skills. As she was saying, it helps you process these procedures, process the information you're dealing with, and really help maximize your patient's outcome. Those things, as you are building up those skills, you're obviously building up your confidence. And unfortunately, in the emergency department, we do see some unfortunate events. And having this ability to reflect and to think about things in a slightly different manner also helps us with our resilience. So as I mentioned, reflection, we do see quite a few traumatic events. I think everybody in here can probably think back to your last 2 or 3 shifts and there was something that bothered you. You want to take that step back and reflect on it and say, how does this affect me? What could I have done differently? How does this affect my patient? How does this affect the rest of our staff? And by doing this, you can really process these events. It can actually help bring your enthusiasm back and really give you the catharsis that you need to be able to come back to the emergency department the next day and deal with a whole nother set of crises. And how does this apply to EM? I guess the question really is, how does this not apply to EM? I think all of us are sitting there thinking like, I need to process this. I need to work through this issue. And I think narrative medicine and emergency medicine really do go hand in hand because there's quite a bit that we see on a daily basis. And it's not just us sitting up here thinking, oh, like we all like narrative medicine, we all incorporate it in our practices. There's actually studies that have been done that show that narrative medicine helps. This is a really nice study that was done looking at how incorporating narrative medicine into EM curriculum can help residents deal with things like improving their empathy and limiting their burnout and their stress. So it's definitely a win-win for not just the patients, but for us as well. This is, I think, a quote that we can all relate to. This is from a book called Back from Burnout by Dr. Frank Gabrin, who unfortunately was the first U.S. emergency medicine physician to die during the COVID-19 pandemic. Excuse me. He published this book back in 2013. And I just want you to stop for a minute and think while I read this quote. And the quote is, "Inside the emergency, the angel of death is in the room. The pressure is intense, yet there is a calm, a peace, like being in the eye of the storm." Now, I think all of you have been on the receiving end of an EMS notification that there is a multi-vehicle crash coming in or a multiple gunshot scenario happening. And you have that moment of like, oh no, like this is happening. But then that being able to reflect on things that you've been through previously, think about what's happening, what you have to do, that sense of calm does come. Might be a little bit chaotic after the fact when you actually stop and think about what you've just been through. But I think this quote really sums up what we do on a daily basis.
So, integrating narrative medicine into emergency medicine, not like the easiest thing to do, right? Because emergency medicine is sort of late to the game, not really a big adopter of medical humanities into mainstream education. So, there's already, the didactic schedule is pretty tight. There's this like baseline skepticism around the utility of the humanities, right? Ultrasound, critical care, very obviously important to what we do. Medical humanities, you have to dig a little bit deeper. So I was very fortunate in being able to engage some of the educational leadership at one of my friends' residency places, and I was able to create and implement this emergency medicine narrative medicine pilot program, which consisted of 2 sessions. There were about an hour each, and they were scheduled during regular resident didactic time, which is important so that we don't eat into resident like free time. And we use this curriculum to focus on these concepts that we took from narrative medicine: thickening the patient story, narrative competence and humility, practicing reflection, and demonstrating the importance of perspective taking. So this is a really cool video. It's called Dangers of a Single Story by Dr. Adichie, who's a professor. It's a beautiful TED Talk. It's a great example of a TED Talk, too, if you guys want to check it out. And it really kind of speaks to how stories are told by the majority and the powerful, and how that can shape our implicit biases. So it's a beautiful thing to look at. And so we use this in the curriculum. We also use prompts like this, like what have your patients taught you, to try to bring them to the center of their interaction as their educators and shift that power differential a little bit. We've done things like deep reading of a painting. This is a painting that we use, and every time I use it, I get a new perspective from a resident, which is insanely cool. And we also introduced the concept of parallel charting by Rita Sharon, who talks about writing a parallel separate chart about the patient, things about the patient that aren't important or they don't belong. They aren't important to the EMR or don't belong there, but they stood out to you and affected you. Um, we also did this really cool activity. It's called the pain scale. I don't know if you guys have read it. It's beautiful. It's 11 parts, and it goes from the 0 to 11 scale. Sorry, 0 to 10 pain scale, each different number, and the author writes something different about each scale. Like 0, am I not supposed to feel anything? Does that mean that I'm dead? Is that good? It can't be good. So it was very interesting to have them read this and then kind of follow it up with old magazines, scissors, markers, and construction paper, and they all constructed their own pain scale. We encouraged the faculty to take part as well, and it was just an incredible experience that everyone enjoyed. But don't take my word for it. We did post-session surveys after each and every session, and they were completely anonymous. And not going to bore you with stats, but overwhelmingly positive responses, with 89% of the respondents feeling that narrative medicine was important to their education. So since then, we've kind of taken everything we've learned about what we did well, what we could do better, and we've created a revamped, narrative medicine and emergency medicine 2.0 curriculum. Perhaps the biggest change being that I've now incorporated Kamna, and she's helping me develop the second iteration of it. As a part of that revamped curriculum, we've started to talk about narrative medicine during orientation. Orientation is a great time to incorporate things like this, where there's a little bit more flexibility and you can do a little bit more. We introduce them to the concepts of narrative medicine and medical humanities, and this is a small part of it, this prompt, which is think about your life as a story. Who are the main characters, and use them to introduce yourself. And some of my residents here actually did this, and they had a lot of fun, right, guys? And yes, exactly. They're showing to give you the hands up, the thumbs up. And we get some really cool. Things like somebody introduced themselves from the point of view of their teenage kid, or their dog, or their medical instrument. Or their musical instrument. People use real and made up characters like Darth Vader or Morgan Freeman to talk about themselves. It's really cool. And of course, it's not just all arts and crafts and cool stories. We always ask them, well, how do you bring this back to your clinical care? And the responses are always very insightful. So the revamped program, again, 1 to 2 sessions, including the orientation one. And these are more of the things that we're sort of focusing on.
So one thing that we've been doing in Pittsburgh is we've introduced a subject called medicine and society. And for this session, rather, I've been going through common popular press, things like New York Times, the Boston Globe, Stat News. If anybody has checked out Stat News, it's a great resource. Usually what these articles are they're related to medicine, but they're not strict randomized control trials and not retrospective studies. So one of the things we've really been focusing on lately is just the role of prison health and what kind of health care do people get in prison. And we are the receiving hospital for the county jail in the Pittsburgh area, so we see a ton of prisoners. And it was really interesting to see the residents' reaction as they were starting to get introduced to the fact that their prison health is kind of a misnomer. That's if you get some medications, you're lucky. If you actually make it out of there without coming to the emergency department, you're actually doing very well. So it's really helped us, and we've now come up with a bridge program. So we have a program for people who are released from incarceration. We have an outpatient clinic that the internal medicine department has now set up, and we can refer people to this clinic to help them get the medications that they should have had when they were in prison, and also to get the medications that if they actually were lucky enough to get medications in prison, to continue those as an outpatient. Because when you're discharged, when you're released from prison, you are not given your discharge prescriptions, which was another eye-opening thing. We've been also working on the fact that incarcerated patients aren't treated for hepatitis C. And if you think about just the statistics you hear about from prison, that's a public health issue that we can easily address if we can only get people to listen to us. So I think it's been really eye-opening to have our residents see that there are issues other than what's said in Annals of Emergency Medicine or in JAMA. And now it's to the point where the residents are sending me articles that they want to discuss at conference. So I think that's definitely been an improvement and something that we're going to continue going forward.
And I'd just like to share how, we've talked about written texts, poetry, we've talked about mainstream media articles or long form essays, but we know that narratives exist everywhere. And I'd like to share with you the ways in which narrative medicine can be leveraged with visual art. So we've all heard the saying, a picture is worth 1,000 words. So there are stories in visual imagery as well. And written narratives can be augmented with visual art, or visual art could be used alone as a narrative to deepen engagement, broaden our perspectives, work together with a group to co-construct meaning. And sometimes it's just easier because no one has to do any pre-reading and you just show up. So that part of it can be appealing when there's a time crunch. So in our department, we have an initiative called Health Humanities at Hopkins Emergency Medicine, which has been there since 2018. And part of what we do is a longitudinal residency humanities curriculum that is integrated into our residency didactics. And the hope really is to leverage elements from the humanities, such as narrative medicine or visual art, to get folks to think more deeply, not just about their clinical practice, but to connect meaningfully with the patients that they serve and think more critically about the communities that they serve as well. And so this is something that we start the year off with. We take our interns during orientation to the Baltimore Museum of Art. And there we really leverage visual art to get our interns to share their stories. And specifically, we ask them what their narrative around starting residency is. And we ask them to reflect on their fears or apprehension about starting residency, but to think about it through the lens of a work of art, to deepen their sort of reflection on the topic. And then they write about it and then they share it with each other. And so we use that work of art as sort of a filter for them to kind of safely discuss their thoughts and fears about starting residency. The interns know each other, right? You start orientation, you build some camaraderie, you are all coming to the same starting place, you're all starting residency, so they have stuff in common that helps facilitate that sharing of narratives. But how do we share stories with people with whom we may not have that much in common and that we don't know that well? So as part of our program, we involve other members of the healthcare team as co-teachers. In the past, we've had our peer recovery coaches. We've had folks from our violence intervention program, as well as survivors of gun violence, join us in conference. So how do we create a space where they feel empowered to share their stories and our residents feel empowered to be curious and ask them questions and share their own experiences? So we use, again, visual art as a way to get folks to share their thoughts about a central theme and generate sort of a common language that minimizes some of the barriers or hierarchies that might exist when it comes to otherwise sharing personal stories. And then we not only look at visual art in the museum, but we're also looking at art in the city around us and specifically the spaces that we inhabit. So here's a picture of our residents out on a mural tour of Baltimore, not just thinking about the art that they're seeing, but they're also thinking about the stories that those buildings and neighborhoods tell. They're also reflecting on the built environments that their patients are coming from. And with our medical students, we actually we have an elective where we have them look at the art in the hospital, which is kind of fun that they're all standing around talking about a work of art while people are walking by. But one of the activities we do is we look at the portraiture on the walls of the hospital and we ask them whose story gets told and whose story doesn't get told. So there's really fascinating ways to leverage the idea of narrative. And you don't have to leave your classroom. You don't have to leave the hospital to do it. You don't have to be a literature expert to do it either, because the stories are all around us. It's a question of making space for them and creating opportunities for people to be able to safely discuss those stories.
All right. So, since all of you have been brave enough to actually come to our narrative medicine session, we're going to break you into some small groups here and we're going to go through a narrative medicine exercise. The nice thing about this is that no narrative medicine expertise or experience is needed. And there's no right or wrong answers. This is really just reflecting and getting to go through the experience yourself before hopefully bringing it back to your programs. We obviously want your perspectives and your experiences as we go through this. One thing that you'll realize as you go through more and more narrative medicine exercises is that you might have more questions than answers, and that's part of the process, and that's actually welcome. And again, the old saying is you have to get a little uncomfortable to get comfortable. So you might have to embrace some discomfort during the session. So
So we're going to break you guys up into 3 groups. So you kind of see a natural group here, a group there, a group here. Right? What do you guys think? All right. Yeah, I'm going to ask for volunteer. Then I'm going to ask for a brave soul to read this out to us. Yes. Praise it.
Okay. Hug or ugh. Vaughn was bouncing on the edge of her stretcher, a homeschooler in the late 50s, beat drumming on the stuffed tile like that of an inpatient schoolgirl. She was hurling insults at EMS when they enrolled her into the ER. They had found her asleep outside the police station. The triage nurse knew her from previous visits, mental health problems and substance use, cocaine mostly, sometimes heroin. I extended my hand and introduced myself. When I accepted into the exam room, she popped upright. Hi, doctor, she said, grabbing my hand. After I go, before I can even say another word, she looked up at me with desperate, bloodshot eyes and asked for a hug. A hug, I said? Yes, doctor, she said. She ranted about living in shelters and how sure she made mistakes going, but don't believe the EMS bullshit about drugs, maybe a little crack and a nip here and there, but she's no addict, and what can she do when she has nobody in the world to prove them wrong? Just a hug, she begged. The weight of each passing second pounded against me as I took in her sun-rubbed face. The wrinkles scuffed and her dirty jeans and oversized t-shirt. The air around her smelled of someone going through a tough time, old sweat, stale cigarettes, and greasy food. In my emergency medicine education, I was trained to respond quickly to a wide variety of emergency situations. At no time did I come across one that was urgent in this way. My muscle tense, my heart cramped. I held my arms. He hugged me. To be completely honest, she hugged me.
Great job, Will, one of our aspiring EM physicians.
Jerry.
Same difference. So just amongst your groups, if you guys want to just talk about initial reactions and how this made you feel. So should I advance it to that? Can you guys incorporate this gentleman here? They're a real friendly lot there. Oh, they're splitting. Okay, that's
Yeah.
fair. That's good news.
Yeah.
People are still talking. We should just let it go.
Yeah.
They're amazing.
That's another thing I don't like to say, like, to everyone.
Oh yeah.
Yeah.
Celebrities do their thing.
Just start saying now.
I miss this today. Like, we're using one of your other pieces.
We should have tried it. Told them.
Oh, yeah.
See, somebody falls and breaks something. So we should launch on SAEM medical modeling. Should that be like a sub? Yeah, 70 people sign up. Lots of time.
Maybe we should do the debrief as a large. We can let them share their stories with each other. We should do the debrief as a large. Should we tell them?
Three minutes.
So, 30 minutes off. They're not.
Okay, all right.
I feel like SAEM sometimes is just present for me. We did an improv session in the semester. The least of it.
This should have been the story. Because we were all going to have to be live.
So the rest is-
Okay, I think we should. Yes. You're all welcome to keep talking for a little bit, but the next step is, we're gonna have you write. So if you have something archaic like pen and paper, you can use that. Otherwise, you can whip out your phone and use your notes app or text yourself, whatever the case may be. But we would like for you to now individually just write what comes to mind. Write about a time when you've opted for an UG rather than embracing the hug. So just take a couple moments and just free write. No one's going to be put on the spot to share what they write, but just take a couple moments to reflect and write.
Attribute it to Jay.
Should we ask them if they're willing to share with their small groups? They can.
Yeah. Okay.
We'll give them 2 minutes.
Yeah.
Someone writing, someone just sitting.
I mean, one of the last next sessions for what?
Hmm?
I think it was before the last text. We were good with the photographer. Okay, so hopefully people have. Oh. So hopefully people have had a chance to do a little bit of writing. And if you would like to share what you wrote in your small groups, feel free to do that now.
Or you can share about the experience of writing if you don't want to read out what
Yes.
you wrote. But if
Yeah.
you feel up for reading what you wrote, please feel free to share with your small groups, and then we'll reconvene as a large group in a few moments.
You know.
He's writing my license for on the back of a flyer.
I kind of want festival why was it so much easier to talk about someone else's writing and not your own?
Oh, that's
Because they were like, oh, my first time, right?
yeah.
That's a great question. You know, all the groups. That's a good question. Where did I write? Yeah.
Yeah.
All classes, so I teach one class on narrative bias and healthcare bias. Like exposure, by cognitive decision making as principal application. The one I taught this semester is all of us review emergency care, and they how we conceptualize emergency real time and it's influenced with media or like legislation. Undergrad. Oh, that's really fun. I just enjoy. They're like that's
I know, right? And hopefully it's not that.
yeah. So like they technically hired me as like faculty admin, so they find out. They actually have a major called medicine science. Oh wow. Which is one of the most popular majors. Big next to it.
Interesting.
It's a really nice way to get science oriented, engaged with like liberal arts.
Yes. Absolutely. We need more of that.
All right, it's 4:30 seconds.
Yeah, I think we have more. I think I should ask that question.
Okay.
Yeah. I shut it off.
Still talking.
Yeah.
There's a guy talking who didn't write anything at all. He's talking about how he really
All right. Yeah.
Okay. All right. Just skip ahead to the debrief slide. Okay. So thank you all for engaging, and you're obviously very welcome to continue the conversation. But since we're ending, kind of coming towards the end of the session, we do want to chat with you all about what the experience of what you just did was like. I did have one question. I noticed, when we were reading, right after we read the story, there was immediately like a lot of conversation, and then when we asked everyone to kind of talk about the story that they wrote, it was silent. And I'm just curious if anyone would want to share, why is it so easy to talk about someone else's story, and so challenging potentially to talk about our own?
Hi, everyone. No, I mean, I think the difficulty I had is just kind of like the general embarrassment sometimes of being in a space that you're not completely aware of how your story may be embraced. and not knowing really how well that will translate to other people. Whereas if it's someone else's, it's kind of a third party. We're all very analytical anyway, so it's very easy for us to pick and choose what's important. But I think knowing some of the people in my group did help, obviously. That was my big thing.
Yeah, so you're kind of getting at the idea of the vulnerability involved in exposing some part of yourself, but then you're also pointing out that storytelling is a bidirectional activity. There's a teller and there's a listener, and you never know what the listener is going to take away from your story. And I was just thinking about this, like, we talk about all the time how a patient's story evolves depending on who's talking to them, but they're also trying to make an impression. They're also trying to make the case for why they deserve your care and your attention. And just what you said just makes me wonder about, like, what a scary experience that is, that you have to tell your story in a way that's compelling, that gets you the care that you need, and how scary that can be for a patient.
Oh, I was just going to say it takes time to remember which story you're going to tell. I think that's why there was a dichotomy between a presented story versus thinking about which story you're going to retrieve. But yes, I agree with you with what you just said, the sort of duality of the storytelling process, the giver and the receiver. And I think, you know, I know for me, like they're like parents who'll tell their children, like, if you're going to the hospital, wear good underwear today, right? How you present yourself, you feel like that will take me to the front of the line. That will make me worthy for my story to matter to this person because you're trying to connect in some way.
Thank you. That just made me think about how I have this like chronic recurring nightmare of wearing old underwear and being like a trauma patient in in RED. But I probably shouldn't have shared that story. That's probably not the story to share. You said there was one back.
We all have the same recurring nightmares, so we can totally relate.
Same thing where I try to remember certain scenarios and I can't. For me, sad stories stick around a little bit longer than these kinds of stories. So for me, it's all blur. I can barely remember what I did 2 days ago or yesterday, but it's so for me to come up with a story about this particular problem was particularly difficult because I still remember. It's tough. We just do so many things. We have so many shifts. We have family life, personal life, and this particular one was difficult for me to come up with something.
For me, I would say in the story we have someone choosing the hug, and it was nice and great. But our stories are about us taking the opposite direction, so I think we'd be less likely to want to share because we look bad.
Anyone else?
No, but what I love about the process is that I would have said it's like opening a file drawer in a file cabinet, but that's so old school. It's like clicking on a file folder and all of a sudden you remember all these stories. So they come streaming back to you. So it really, while I'm listening and I'm trying to listen hard, I'm thinking about so many stories that happen to me that are kind of comparable. So I think it really helps. It's a good practice.
It's my job.
Grounding experience. I think what I mean by that is like similar to what was just said. I don't have any hug moments. I only hug, right? Like that's what my mind goes to, and it's like I have this like positive bias or this schema of who I am. I'm a good person, and I wipe away them. It's like a mix of the ER dementia, but like it's selective memory. If I only remember the good times, the good experiences, and it like takes a moment to reflect on like, no, I have weaknesses. We all have weaknesses, and like, while really the first line of my written is, I'm always frustrated with EMS being mean to patients. And then like that was truly like the grounding of my story. And then I realized it was like a moment of recognition of I have those moments of like negative experiences. So I don't know. It's like a humbling experience because otherwise I'm just forgetting the bad parts of myself, which is not good.
Anyone else? Sorry. Okay. Thank you. I think I'm probably one of the more, I don't say unique ones in here because I'm
PEM on pediatric emergency medicine, and I did a pediatric residency and then the PEM fellowship. For some reason, the question prompt when it came up, like when did you opt for UG, I would say because I'm peds, I'm nice, so I hug everybody. So I didn't have like a moment I can think of where I opted out from a hug or some kind of equivalent, but it actually I kind of agree with a lot of what people have mentioned. Like we bury down a lot of stories, and recalling it is not that easy. But the thing that popped up for me was actually a moment in my NICU rotation in pediatrics. We had like a very sick newborn that had like a very rare disease, incontinentia pigmenti, like a intractable seizure, was never going to have any meaningful life, and essentially was not tolerating pentobarb, like the cardiovascular side effects were so great that like every time they titrated up to stop the seizures, your body wouldn't tolerate it, and so the family came to the conclusion ultimately that there was no meaningful life for this newborn baby, and there was a plan to extubate, essentially to terminate. So the family asked me if I wanted to be part of the baptism for the baby before we did this, withdrawal of care. And I'm Jewish. I've never been to a baptism, and that is just not something, even with the medical care, that I ever thought I would be facing or being part of. And so in that moment, I feel like I could have said, "That's okay. I don't need to be part of that. Like I'm the doctor." And I was shocked by how emotionally like affected I was by it. I was like sobbing because it finally made me see the baby. When you're in the NICU, sometimes like you're hooked up to so many things, and then babies are in like box basically, that they don't look very human like. But seeing the baby, view it as like a human being, and getting baptized, and the family, it was like very emotional. And then it came for the time where we had to extubate and withdraw care, and I can't even believe, like, I remember it so vividly, like there was like a light switch as soon as I had to take on the role of the doctor. It all stopped like completely, and it's kind of weird that stuff like that can happen. So, but I feel like if I declined joining the baptism, I think that would have been like a loss to not have participated. It's like you see that patient like a real human being, as opposed to the box that you're trending the numbers and the values. Yeah.
When you use this, it makes me think of like how stories are such a double-edged sword because it is protective in some way that thank you. It is protective in some way that the person in front of us isn't a person, right? Because then you risk sort of shedding that persona of the professional that is treating their malady. And as soon as a story is in the picture, you're treating a person with people that either depend on them or that love them, and it can feel dangerous, it's a form of vulnerability to be open to somebody else's story. And I think in our work it's so hard to balance, taking on someone's story or letting it get swallowed up with dementia just to protect ourselves. But I wonder in the long run, what impact that burial of stories has. Thank you. Well, I guess we only have a few minutes left. I don't know if there's anyone here that's already done narrative medicine work with their trainees or with their group who might want to share their experience or any particular tips they might have, or if anyone has questions about this work or integrating this kind of work, we're here. We have a couple of minutes if anyone wants to share anything else.
I would just say, I mean, and this is great. I think we also had this earlier storytelling moth hour type storytelling session. And I think every single ER physician has that story, maybe a few of them, that just is the weight on their back that they carry. They tell no one, maybe their therapist, but it's like something that maybe went horribly wrong or something they thought they could have done differently. And there's always these medical legal implications. But I do think the storytelling process is therapeutic, and a session like this is therapeutic. But I wonder how you make the place safe. It's easy to tell the stories that uplift us in the story itself, where the good guys at the end, the patient survives, everything works out. But those are not the stories that haunt us. So how do you tell the stories that haunt us?
Actually, our resident haunted story expert is sitting back there. But we have a night of reflection with our residents, which is literally about talking about bad outcomes. The whole thing is focused on bad outcomes, and we start with what we did here, which is the indirect approach, where you start with somebody else's story. And so we will pick something. Last time we were using a piece from the New Yorker that was written in the 60s or 50s, and it's about a doctor who is out for a run and fails to save a child that falls under a piece of concrete or something. And we start with talking about that person's experiences, and I think that establishes that sort of safe container once folks see how forgiving or welcoming people are. Of course, the medical legal aspect, I mean, we ask people what you talk about here stays here, change details, whatever the case may be. But I think starting with someone else's story, like we just talked about here, is perhaps establishes some of that safety.
I know our residents were really hesitant to try to get into this realm. And one thing we started doing that it's not from a medical legal perspective, but we started bringing families back to resuscitations in the emergency department. And I think that really let the residents see that not all outcomes are good, but it also exposed them to the family situation and the family perspective. And it has made things a lot easier going forward. And it has actually humanized our patients again. And it's hard to step back during a resuscitation or a code to look at that, but I think it's really helped everybody process things, and it's made people a lot more willing to be open with their thoughts after watching a family watch a loved one die. So I think it was somewhat, some people thought it was harsh, but once we started doing it more, they realized that it actually made the whole process a lot easier, and that's been able to open discussion in other areas. So that might be one thing to consider.
Do you want to just do the conclusions and our just from Oh, sure. Go ahead.
Okay, so we want to thank everybody for coming. We really hope that you've learned something here today, that you enjoy going through the narrative medicine process, and that you can go back to your programs and hopefully implement things that way. But we definitely want you to take away a few points. One, that narrative medicine absolutely belongs in emergency medicine. It is, with a little bit of work, relatively easy to implement into your programs. And I think it will just help everybody develop their empathy and just relate to their patients a little bit better. So if you have any questions, please feel free to contact us. And thank you for coming.
Bedside. Who's coming?